Now that you've heard presentations on the importance of orthotics and feeding, we're going to go into speech therapy, which also ties into feeding. How we use our muscles for feeding is the same as how we use it for speech, and we can use good feeding skills to get more articulate speech. My presentation is the importance of motor-based speech and feeding therapy in the Down syndrome population. Just a little background on myself. My name is Vanessa Anderson Smith, and I own a speech therapy private practice in Sioux Falls, South Dakota. My private practice focuses solely on motor-based speech and feeding disorders, and about 90% of my caseload has Down syndrome. I'm a Talk Tools Level 3 certified therapist, and I've received advanced training in prompt. I have to admit that prior to learning about oral placement therapy, I wasn't a huge fan of working on articulation of speech. I really struggled with the idea of only giving visual and verbal cues for speech production, especially with my motor speech disordered patients. And by visual and verbal cues, I mean saying to a patient, look at me, listen to me, now say it like me. When I went to my first Talk Tools course, it was the missing link in my therapy. As my instructor stated in the first half an hour, physical therapists do not look at their patients and say, look at me, listen to me, now walk like me. A light bulb went off for me, especially because I was working in rehab and skilled nursing facilities with stroke patients. I watched the PTs and OTs that I worked with use equipment and muscle-based exercises before transferring those skills into functional activities such as walking and sitting to standing. So why haven't speech therapists been using functional muscle-based exercises for speech production? In the next half an hour, we're going to have a small overview of motor speech disorders. Then we're going to look at how they relate to Down syndrome. I'm going to talk about techniques and therapy materials, as well as how to set up a therapy session and showing some videos. Let's go into motor speech disorders. First, we have apraxia of speech. There's childhood apraxia of speech and apraxia of speech, which is considered an adult onset. Because this presentation focuses on the treatment and diagnosis of children with Down syndrome, we will only be focusing on childhood apraxia of speech. There's oral apraxia. Not all patients with childhood apraxia of speech have oral apraxia. They can be tied together, but it's fairly rare. Oral apraxia is when a patient is unable to execute certain motor functions, such as licking the lips or sticking the tongue out. And lastly, there's dysarthria. There are 6 variations of dysarthria, but we're just going to look at it as a whole today. Let's look at childhood apraxia of speech. When we talk about this, I want you to think about motor programming. Children that have childhood apraxia of speech are born with neurological impairments, or if there's an injury or stroke prenatally or during birth. These kids have difficulty with the precise movement of speech and the planning of it. The best way for me to explain this is the brain knows what it wants the muscle to do, and the muscle cannot execute that function. A lot of times I tell parents, it's no different than me telling you to move your ears. You can think about it all that you want, and it's not going to happen. You can imagine how frustrating it must be for the children with apraxia of speech. Symptoms include vowel errors and distortions, inconsistent errors in speech. This means on 3 out of 3 trials, they can each be different. Intelligibility with single word utterances, but as the length of the utterance increases, intelligibility will decrease. We have so many children that are good at saying one word or two words together, but in phrases and sentences, they completely fall apart. Initial and final consonant deletion, cluster reduction, syllable omissions, substitutions, and distortions. Groping for speech, this just means that the child is in a constant state of searching for the right position to start. Those are the high points of the symptoms and characteristics. There's many more. You can visit the following website for a complete list. Let's look at dysarthria. With dysarthria, I want you to think of muscle weakness. And how many kids with Down syndrome do we see that have muscle weakness? It's a lot of them, if not all. There is no issues with the disturbance of programming for speech. This is all due to muscle weakness. The symptoms are slurred, choppy, mumbled speech, slow rate of speech. There can also be a fast rate of speech with mumbling, limited tongue, lip, and jaw movement, abnormal pitch and rhythm, and changes in vocal quality such as a hoarse or breathy voice. Speech can sound nasal or stuffy. Again, this is just the high points. There's many more. You can visit the following website for additional information. Now, looking at this specifically with Down syndrome and motor speech disorders, many times we find ourselves wondering, is it childhood apraxia of speech? Is it dysarthria? It is most likely both. Research is coming out that we're finding that it's not one or the other, it's a combination of them, because it really does all come down to motor planning. Diagnosis and intervention. As William Shakespeare said, what is in a name? That which we call a rose by any other name would smell just as sweet. Why are we so focused on the label? I'll admit there are times that a label is very important for insurance reimbursement and funding. However, labels are important to me about 1 minute out of my week if I have to write it down. What's the most important is that we treat the speech characteristics and the deficits, not the actual label. This is all gray area here. You can drive yourself crazy trying to figure out if it's apraxia of speech or dysarthria. Let's just look at how the child presents with speech and go from there. It's going to be much more functional. In regards to therapy, intensity and frequency is always a big question of parents and therapists. When we're talking about intensity, I'm referring to how much motor practice is the child getting in each session. Are they completing 40 exercises and speech productions or 100? Frequency is how often are these new motor patterns being introduced and practiced. Is it once a day, once a week, 3 times a week? Research is going to show time and time again that patients with motor speech disorders need intensive and frequent therapy sessions to teach new motor pathways. However, I'm going to give you my personal word of warning that for a lot of children, you can overdo therapy. I don't recommend formal speech therapy more than 3 times a week due to the burnout of the client. I think it's much more important to incorporate therapeutic exercises into your family's daily life. For example, using chewy tubes right before a meal to get the motor plan of chewing going. You can practice bubble blowing and horn blowing in the bathtub at night. You can just create a language-rich environment. It's probably the most important thing you can do so that a child wants to communicate. The more they want to communicate, they're practicing all those motor pathways that we have in therapy, but it's in a functional environment. So it's a win-win situation. Let's talk about how to set up a therapy session. This is how I have set up my therapy sessions for the last couple of years. It's what I find to work best for me. The first 5 minutes or so is consulting with the family regarding struggles with eating or the oral placement therapy exercises within the last week. Then we always go into a sensory motor warm-up, also known as a pre-feeding program. Feeding and oral placement therapy exercises is next. And for my older kiddos, I will end with traditional speech therapy, which will be drills and flashcards. However, for younger children, we will incorporate verbal expression throughout the session by requesting toys or food. I can also end with a therapeutic play session. Let's look at a sensory motor warm-up, also known as a pre-feeding therapy program. This is a very important step and it should not be omitted from your therapy regimen. The goal of this is to support safe, nutritive, and effective feeding, and that's per Lori Overland and Robin Merkel-Walsh. It helps to prime the sensory system to get the child ready for therapy or eating. It's going to work with hypersensitive, hyposensitive, and mixed sensory systems. There's various tools that we use. For infants, I'll use a gloved finger. We can go into using a toothette, which is spongy on the end. We get it wet and we complete exercises with it. You can also use an arc probe. They also have nook brushes that are round. And one of the most popular is using a Z-Vibe. There's various tips that you can use with this. There's a small green tip, and there are some round tips. There's a lot. You can even get spoon tips on here. You can turn it on for vibration or leave it off, just depending on what the child needs. I have a lot of children that were major sensory seekers at the beginning of therapy. They loved when I used vibration. They would put it in their mouth. They would bite on it. They couldn't get enough. It really centered them and grounded them. However, within a couple months of therapy, the vibration became much too stimulating, and we had to end up turning it off or backing down to using a toothette. And this was great to see because the sensory system was normalizing. And it just goes to prove that you can change the sensory system. You have to do this, though, in a very systematic way. You can't just go into the mouth and go all over. It's very important to never cross midline. That can be very disorganizing for many children. And as a therapist, you have to watch the cues of the patient at all times to know when do we need to back off and when do we need to add more input. It's our job as a skilled speech therapist to be able to read those cues and know that some days, some children might be more reactive than others, and then we have to back it down. We're going to look at a video next. This is of little Braden. He's an 8-year-old male with Down syndrome, and I've been seeing him for almost 2 years now. This sequence is the first thing that we complete every therapy session. He used to have issues with the vibration going on, and we've worked our way up to where we can use vibration for a little more input, and he tolerates it much better. I start out with C stretches in the cheeks, then resistive cheek exercises, and then we go into kisses, which help with lip rounding and protrusion. As you can see, I'm never going to cross midline, and I'm always going to count out as I do it so he knows when the end is. Let's take a look.
Okay, 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Okay, Now we're going to squeeze. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Okay, kisses. 1, 2, 3, 4, 5.
Okay, that is little Braden. And as you can see, I used a Z-Vibe with the yellow prefer tip, and it was turned on. Looking at oral placement therapy. OPT is a term created by Diane Barr and Sarah Rosenfeld Johnson back in 2010. What the traditional approaches lack, and by traditional I mean only those visual and verbal cues of look at me, listen to me, now say the word like I say it. What those lack and what OPT adds is the tactile and kinesthetic input of speech and how the articulators feel during the production. The goal of OPT is muscle dissociation. This means the fine-tuning of individual muscle groups to work on their own. For articulate speech, there must be independent movement of the tongue, jaw, and lips for precise speech sounds. There is a lot of debate going on in the speech therapy community about OPT versus non-speech oral motor exercises. There is a big difference between the two. Non-speech oral motor exercises are exercises that include various motor movements such as puffing out the cheeks, wagging the tongue outside the mouth. Opponents will say that there is no need in speech for doing those types of exercises, and they are exactly right. We do not need to puff out the cheeks for speech. We don't need to move the tongue outside of the mouth. We actually want exactly opposite. We want to retract the tongue. But what is there a need for? We use the Talk Tools horn hierarchy for abdominal grading and breath support. That's essential for speech production. And we'll use the straw hierarchy from Talk Tools for tongue-based retraction. We need tongue-based retraction for every single speech sound except for the TH sound. Those are just two examples of the countless OPT exercises that we can use. If you want to read the full research study, I've posted a link here. I'm going to show you a few of the OPT tools that we use. The first are the chewy tubes. These are resistive tools that we have patients bite on. They start easy and get harder. They progressively get harder. Not only do these help with feeding, but it does help with speech because the more strong and stable the jaw is, the better the tongue and the lips are going to move for speech. The straw hierarchy. This is a picture of the straw hierarchy from Talk Tools. This is a progressive straw kit that starts with a run-of-the-mill straw that we cut off. This works as a lip block, and it ends up going into a 2.5-foot straw. Each time you get more and more tongue-based retraction. Bite blocks are the ultimate jaw strength and stability tool. This is the sensory-friendly set. This is from Talk Tools again. It teaches the fine jaw grading that we need. And this is what we need for muscle dissociation. You start out with number 1 is the teeth closed, and then number 2 all the way to number 7. This is essential for great speech production. If you see when I make the E sound, E, my teeth are slightly apart. But if I go into ah, there's a big difference there, and it teaches all of the grading positions individually. Another one I'm going to show you is the Talk Tools horn hierarchy. I put it in my own little case here. This is also a progressive horn kit that starts out with the easiest horn, very easy to blow in, and it gets much, much harder. Here's one of the later ones. So what that does is it teaches the abdominal grading that we need for breath support. A lot of times children with Down syndrome become unintelligible because they run out of breath and they try and squeeze all these words right into the one sentence. I want to tell you that it's extremely important to follow up all of these exercises with a functional speech or feeding task. We want to transfer those skills into what we're going to do every day, which is speak and eat. So these aren't going to do nearly as much good by themselves unless you teach a child how to use them within speech and feeding. I'm going to show you a video of, first of all, Brayden with the chewy tube hierarchy. We're using bilateral placement of the yellow chewy tubes because he has asymmetry in jaw strength. His right side is weaker than his left. I try and fade it out to only have him bite on the right side. He starts to demonstrate a jaw slide, so I have to bring both of them back in.
Okay, oh wait, 1, 2, 3, 4, 5. 1, 2, 3, 4. Now let's do, oh, just wait. 1, 2, okay, let's keep our chin nice and straight. 3. 1, 2, 3, 4, 5. Good.
That was Brayden. I'm going to show you a video of Eman. Eman, this was during her initial evaluation. She was 2.5 years old at this time. Only receives formal traditional speech therapy, I should say. We're teaching her how to blow through a pre-hierarchy horn for Talk Tools. This is just to teach the skill, and then we'll go into the Talk Tools horn hierarchy. You can see that I'm giving her cues on, tactile cues on her diaphragm. I want her to push up air through her stomach and not use her shoulders and clavicular breathing.
Yay! Good job. Go. Yay! You're so good. Do you want to do one more time? Good job. High five.
Feeding and speech. There is a significant relationship between speech and feeding because how we use our muscles for feeding is how we use our muscles for speech. Poor feeding habits in infants will have long-term implications for speech production. There's many children with Down syndrome that don't display overt deficits with feeding. However, in a motor-based speech program, we use feeding to facilitate the dissociated muscle movements needed for the small, precise movement of speech. The oral sensory motor skills for speech and feeding cannot be separated. And while there may not be an exact 1-to-1 ratio, there is a significant relationship between the two. That is per Lori Overland and Robin Merkel-Walsh. For example, in therapy, I'll incorporate a snack and I'll place a stick-shaped object such as a pretzel onto the back molars with instructions to the patient to use their tongue to keep it on that same side. That's going to work on tongue retraction, tongue lateralization, stability of the cheek muscles. It's really important to keep an eye on feeding as an infant because poor feeding habits can have long-term implications on speech production, such as encouraging a tongue thrust, which we're going to talk about next. A tongue thrust or a reverse swallow, also known as an immature swallow, is the biggest hindrance that I see in the Down syndrome population for feeding. It's called an immature swallow because typically developing children and children with Down syndrome will thrust out their tongue when they are nursing or bottle feeding to expel milk from the nipple. There's some research that says it will be appropriate to have a reverse swallow until age 8. However, that makes the hair on the back of my neck stand up. I like to see it resolved long before then, or at least addressed before then. If the child continues to demonstrate a reverse swallow, the tongue will stay in a forward position, which will distort speech sounds, cause a tongue thrust, and have dental implications as well. So usually a multidisciplinary team of a speech therapist, dentist, orthodontist, and physician is needed. Again, I'll use stick-shaped food placed on the lateral molars for tongue lateralization. This is important for speech because we have to teach the tongue to move side to side before we can teach the tongue tip elevation, which we need for the T, D, and N sounds. Gum chewing is another great exercise. It promotes jaw grading, jaw strength, tongue lateralization, and buccal stability. Talk Tools has a great gum chewing hierarchy as well. Time for more videos. I'm going to show you a video of Lincoln. He is 22 months old at the time of this video, and it was really neat. It just so happened that this is the first time he's ever been able to drink out of a straw, and we caught it on tape. We've been attempting for the last few months to drink from the straw. He was biting on it, pulling it out. I couldn't get that motor program going the way I needed it to. So I scaled back and I went to working on a small syringe and having him round his lips around the syringe. He did that wonderfully, so I said, let's try the honey bear again since he got the motor plan with the syringe. We transfer that into the honey bear, and as you'll see here, he puts it all together. It's really neat to see. I've been seeing Lincoln once a week since he was about 8 months old.
Swallow. Got a lot in your mouth.
What we're using there is the honey bear. That is a pre-straw hierarchy tool that we use to teach straw drinking. He's probably ready now. We've worked on it for a couple of weeks. He's ready to start with the first straw of the hierarchy. Again, this is important. We want to have straw drinking because we need tongue retraction for every single sound except for the TH sound. I'm going to show you a video of Braden. Again, Braden demonstrates a reverse swallow. I just want you to see how it looks, and you can understand more of the implications it will have dentally and to speech. Braden has great awareness of his reverse swallow. We've been working on it a lot. Like I said, he's 8 years old, and We started this before he was 7, and I'm always surprised at how quick these kids pick it up and understand that they're not supposed to have their tongue out. So you can start working on it at a fairly young age.
Okay.
Try again and keep your tongue in. It's hard, isn't it? Okay, one more drink, teeth together, swallow. The cue that we use for him is sip, teeth together, and swallow. And that is oral placement therapy in a very small nutshell. If you can't tell, we use a lot of hierarchies in therapy, and let's look at verbal expression now, which we use another hierarchy. I think that this picture is a great example. It starts off with isolation, and you have to move up through the steps through conversation. I tell parents that even if it's possible, I don't want your child to go into speaking in full-blown sentences tomorrow. I want them to go through the building blocks that we need that are essential for speech. Isolation, syllables, words, those are all important. Now, some kids may move very fast throughout it, and that's okay, but we don't want to ever skip any steps. I have some nonverbal children that I teach babbling to during play. They don't even know how to babble, so I'll sit and play with the car, and I'll say, ba, 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 da, 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 and I just bombard them with that, and pretty soon they'll start to babble, and we just start building on top of that. The two approaches that I use during verbal expression that I found to be most effective is the Kaufman approach and prompt cueing. Nancy Kaufman is a speech therapist that developed apraxia cards. They're known as the KSLP cards, and they're based on a hierarchy. What it does is it teaches successive approximation. So this means, here's one of my cards. This is bubble. You see on the back. We're not going to jump right into bubble. We need to go through these steps. So we start with ba. I'll continue to shape it to ba, bo. And then I'll add the L sound in at the very end. Bubble. We'll work through that. In addition, prompt cues are very effective with a lot of populations, especially the motor speech disordered children. PROMPT stands for Prompts for Restructuring Oral Phonetic Targets. And what it is I use my hands on the patient's articulators on their jaw. I give cues to where their tongue is, on their lips, for the better placement. It's a little tricky to explain, so you'll see it in this next video of Scotty, how effective it is. He's a 21-year-old male with Down syndrome. He only received traditional speech therapy for most of his life. About a year and a half ago, he started a motor-based speech program, and what it's done for him has been astronomical. We still have a long ways to go, but the way that he responds to this tells me that it's never too late to start. I'm using prompt and Kaufman cues with him. And as you can see with the prompt, I'm using my hands on his face to give him cues as to where his articulators go, and he responds very well to it.
B. A, D.
I'm going to help you with this one. So this is daddy, so
I,
D.
I, D. I, D.
This is Toby.
Jeffy.
Toe. B.
B.
Toe.
O, B.
One more time.
Toe. B.
Nice work.
B. Chippy.
Okay, and we're not going to use our teeth. So toe.
So, B.
Now you do it.
So, B.
Nice work.
Okay, that was Scotty. I see Scotty 3 times a week, and we are still continuing to work on good feeding issues, and we're working on consonant vowel productions. That is therapy in a very small nutshell. I want to share a picture with you guys of Eman. Eman was the little girl in the video that was blowing on the pre-hierarchy horn. When she came to me, she was able to say mama, papa, and baba. So all the bilabial sounds. She, like many children with motor planning disorders, she had a very high receptive understanding of language and much lower expressive. What you can see here is the difference between just 2 months of an oral motor based therapy program. You can see that her muscle definition around her lips and in her cheeks is so different. And the best part is we are hearing the results. She maybe had 1 word when she came to me. She now has over 50 words. She's starting to put 2 words together. I know that this is something that her family works very hard on at home too. And Eman is very smart, and she responds to all these cues very quickly. It's been so neat to watch her, because this is a textbook example of what the right kind of therapy and the right tools can do for a child. It's absolutely life-changing. In conclusion, I have some takeaway points I want to make. We do not want to overthink the diagnosis. Let's just treat the actual symptoms of the speech characteristics. You can drive yourself crazy trying to figure out, is it apraxia? Is it dysarthria? Remember that feeding is intertwined with speech. So poor feeding as an infant will result in poor speech. It's important to find a therapist with certified training in oral placement therapy and prompt and get consistent therapy. That's the way you're going to have the best results. And always, always, always follow up OPT with functional speech or feeding activities. Remember, this is no different from what physical therapists do with strengthening leg muscles and then using those skills to help a patient transfer from a sit to stand. I've listed some additional information. The first is the American Speech, Language, and Hearing Association. You can find information on swallowing and feeding disorders, apraxia, and dysarthria. The Childhood Apraxia of Speech Association of North America is a great website with a lot of research on it, on apraxia. The Prompt Institute will discuss some of the prompt techniques. There's Kaufman's Children's Center, which is Nancy Kaufman's website. She's developed the KSLP cards. And TalkTools.com. You can find certified therapists there and purchase various tools for oral placement therapy. I want to thank you so much for attending this conference, and I hope to hear from you soon.